A very good afternoon to you all and a very warm welcome from Vivekananda Institute of Medical Sciences in association with the the Association of Otolaryngologists of India, West Bengal. We are commencing our monthly clinical meet, and I invite our principal, Dr. Sanjay Mohan Bhattacharya, and Dr. Amitabh Roy Chaudhary, head of the department ENT, to please come on the dais. And we would like to hear a few words from them. I request Dr. Momita Sen to felicitate our principal and our HOD, sir.
Good afternoon, everybody. I'm very sorry because you are waiting here for, I think, more than half an hour in this podium, in this hall. So I, on behalf of this institute, means Ramakrishna Mission Seva Pratishthan Vivekananda Institute of Medical Sciences, it's my privilege to be here and to welcome you all in the monthly clinical meeting of otorhinolaryngology. So I know this CME is very important not only for this, our junior students and our faculty members, so it is so important for the institute as well, as because there's so many things you can know. I think as a doctor you know so many faculty members of us, but what are the protocols which are managed in this institute or followed in the institute, so you can see also that thing. And it also increases the face value of the institute. What are the avenue which is available in this institute? So I hope you will enjoy this and you will enlighten our juniors so that they get some impetus and they can improve this healthcare system. Thank you.
Thank you, sir. I now invite Dr. Amitabh Roy Chaudhary to speak a few words, and then we would invite our judges on the dais and start with the program.
Good afternoon, respected seniors, juniors, ladies and gentlemen. It's indeed my proud privilege today to welcome you to this institute, which we usually are honored to have been allowed to host every year one clinical meeting in each year. And I welcome again to all the members who have come from all over the state and the city for this meeting. Without any further, I hope all of you have an enjoyable enriching and academic session, and please do not forget to also have your lunch as we go along. Thank you very much, AOI West Bengal, for giving us this honor to host this program time and again. Thank you.
I now invite our respected judges, Dr. Dipankar Mukherjee, sir, Dr. Bidhan Rai, and Dr. Shubhendu Kaur, sir, to please take your seats. Can I now ask our first speaker, Dr. Debojyoti Dasgupta, to please come on the dais and present his interesting topic on not a tumor, not a stroke, the diagnostic puzzle of skull-base osteomyelitis. I invite Dr. Bidhan Rai, sir, to speak a few words, and he wants to discuss the guidelines of the program.
Okay, good evening, everybody. So we have some new guidelines regarding this clinical meeting, that is 8 minutes for presentation, 2 minutes from question and answers from the judges, and 10 minutes for interaction with the audience, mainly in the form of suggestions, not any questions seeking the deep part of knowledge. This is not that platform actually. What we were discussing earlier, that this is basically a clinical meeting. So clinical case presentation and interaction are more welcome here, not the case series or the data analysis. So in future, all the participants should remember that this is the platform for discussion and sharing atypical cases atypical new management, atypical presentation, to enrich our knowledge and develop our skill. This is that platform. And we are very much fortunate enough that today we have another speaker, our senior-most faculty, senior-most teacher of the teachers, Dr. Barin Rai Chaudhuri sir. He will present a unusual case of hemoptysis or a rare case of hemoptysis and hematemesis. Is it hematemesis? Yes. Okay. Unusual case of hematemesis. And I think it will be better if we can discuss it after the end of this session actually, after the completion of this clinical meeting session. So without any delay, most welcome. Let us start the clinical part. Thank you all.
Thank you very much.
Good afternoon, respected judges, teachers, and colleagues. I am Dr. Debajyoti Dasgupta, and today I'll present my case. Not a tumor, not a stroke, the diagnostic puzzle of skull-base osteomyelitis. This case highlights the diagnostic challenges in central skull-base osteomyelitis, which is a rare condition and often mimics a malignancy. So our case was a 61-year-old gentleman from Howrah who presented to our department with complaints of left-sided facial weakness for 4 months, left-sided headache and deep earache for 4 weeks, and a swallowing difficulty with change in voice and reduced taste sensation since past 2 weeks. 4 months prior to presentation, he had a history of left earache and facial palsy, for which he received 2 courses of oral antibiotics elsewhere, but with temporary relief. And over the subsequent months, he developed an excruciating, deep-seated left headache with otalgia, which was gradually progressive and more troublesome at night. And he also noticed hearing loss in his ears. And later, he developed an insidious onset and progressive dysphagia and a hoarse, breathy voice since 2 weeks. He has a history of uncontrolled diabetes with irregular medical compliance and a positive family history, with no history of any past surgeries or radiation, and he denies any allergies or addictions. Interestingly, there was no history of any ear discharge. On examination, he was alert and oriented, hemodynamically stable, and general survey and systemic examination were grossly unremarkable. On otoscopy, the right ear was normal, the left tympanic membrane was dull, and there was no evidence of any otitis externa or middle ear infection. The nose appeared normal, and on oral cavity examination, the tongue was deviated to left, there was loss of left tonsillopilar tone, the uvula was deviated to right, there was absent gag reflex and sluggish movement of left palate on phonation. The cranial nerve examination showed a left lower motor neuron facial palsy. A tuning fork test suggested a sensory neural loss in the left ear, and palatal palsy with dysphagia and voice changes, and left vocal fold palsy on indirect laryngoscopy suggested cranial nerve 9 and 10 involvement, and tongue deviation to left suggested cranial nerve 12 involvement. The audiometry showed a mild to moderate sensory loss in the right ear and a severe profound mixed hearing loss in the left ear with a B-type tympanogram. The video laryngoscopy confirmed our findings of left vocal fold palsy, and on nasal endoscopy, we saw swelling of the left torus tubarius, but there was no obvious swelling or ulceration present. The CT temporal bone showed bone destruction involving left clivus, petroclival junction, occipital condyle, jugular foramen, carotid canal, and medial pterygoid process. However, the paranasal sinuses were cleared, and the mastoid bone showed no signs of any erosion. And contrast MRI showed an enhancing infiltrative lesion involving the left parapharyngeal soft tissue, torus tubarius, Rosenmuller's fossa, medial pterygoid and longus colli muscles with extension to clivus, jugular foramen, and foramen magnum. So the imaging suggested an aggressive skull-based lesion, but it could not differentiate between a neoplastic or infectious etiology. The CT angiography was done, which showed the internal carotid artery encasement, but there was free flow through the vessel, and the distance of the lesion from critical structures like basilar artery and the ICA was closely studied before any surgical procedure was planned. So a differential diagnosis was central skull-base osteomyelitis, nasopharyngeal carcinoma, chordoma or clival tumor, metastatic skull-base lesion, or any tubercular or fungal granulomatous disease. So the patient was admitted. We started him on injection ceftriaxone with anti-inflammatory agents. Routine blood was sent. A strict glycemic control was initiated in consultation with endocrinology. General medicine, neuromedicine, neurosurgery opinion was also taken. And this patient was started on voice and swallowing therapy. He was also discussed in our joint head neck clinic along with radiologist, pathologist, microbiologist, oncologist for a multidisciplinary treatment plan. So the treatment was monitored by serial blood investigations, where we found a declining trend in both the total leukocyte count and CRP values. And the patient also had subjective improvement in like pain. Initially, he required tramadol injections, and then we could lower down to paracetamol, and then nothing at all. And the voice and swallowing also improved as the therapy continued. So now we were at the dilemma that the patient was responding to our treatment, but we were yet to establish a proper definitive diagnosis. And to exclude malignancy, we need a tissue diagnosis. And for that, various approaches were considered, like endoscopic nasopharyngeal biopsy, a transmastoid approach, a transmaxillary transpterygoid approach, endoscopic transnasal transclival approach, external cervical approach, image-guided percutaneous biopsy, and open craniotomy, a skull-based approach. So based on the location of the lesion and the proximity to neurovascular structures and the morbidity of the procedure and surgical expertise, we chose the endoscopic transnasal transclival approach. In the surgical video, sphenerotomy has already been done, and a posterior septicectomy has been done to widen the transnasal corridor. And after identifying the clivus, drilling was started until we encountered the necrotic bone and inflammatory tissue, from which multiple punch biopsies and curettage was done, and the specimen was sent for HPE, fungal stain, and gene expert. Histology showed features of chronic inflammation without any evidence of malignancy, and gene expert and fungal stain were negative. So our diagnosis was central skull-base osteomyelitis involving the clivus and left skull base with multiple lower cranial neuropathies in an uncontrolled diabetic patient. So our next plan was to continue intravenous antibiotics till at least 6 to 8 weeks with optimization of glycemic control, serial monitoring of inflammatory markers, ongoing swallow and speech rehabilitation, nutritional support and aspiration precautions, and a multidisciplinary follow-up and repeat contrast imaging. In our repeat imaging, on comparison with pre-op and post-op MRI, we can see the disease stabilization without any progression. It is important to note that radiological abnormalities may persist despite clinical improvement in these conditions. So central skull-base osteomyelitis is a rare but life-threatening condition which can have lateral or central variants and has strong association with diabetes mellitus. Though the incidence of 0.22 per 100,000 is low, the stakes are high with a mortality of 10% and around 1/3 of surviving patients having some kind of long-term neurological deficit. And cranial neuropathies usually indicate an advanced disease, so early diagnosis is crucial, but often it's difficult because the condition mimics a malignancy both radiologically as well as clinically. In imaging, MRI is advantageous over CT in case of soft tissue and marrow involvement, but there is a role of advanced nuclear medicine, including gallium-67 scintigraphy, indium-111 WBC scan, and technetium MDP bone SPECT for both localization and tracking of infection. So the cornerstone of treatment is prolonged antimicrobial therapy, strict glycemic control, and multidisciplinary management. Surgical debridement is an important tool to reduce the burden of necrotic tissue to allow more penetration of antibiotics. And to assess the treatment outcomes, clinical improvement and inflammatory markers are more reliable than imaging alone. To conclude, central skull-base osteomyelitis remains a rare but aggressive infection that often masquerades as a malignancy. We should have a high index of suspicion when we encounter patients with uncontrolled diabetes and multiple lower cranial palsies. While imaging is indispensable for defining anatomical extent of disease, the histopathological diagnosis is necessary to rule out malignancy. And to achieve favorable outcomes, we have to follow a quick timeline of early diagnosis, prolonged antibiotic therapy, optimal glycemic control, and targeted surgical debridement whenever necessary. These are my references. Thank you.
For your very nice and excellent presentation. So, number one, what antibiotic you have used? Number two, what is the present status of the patient and present status of the general conditions and also the cranial nerves? Number three, what microbial organisms have you cultured it or any information on that? And number four, as no source of infection clinically was evident in your case, though the patient was a highly uncontrolled T2 diabetic. So what do you think where this primary source of infection in this case could have been?
So the patient was started on ceftriaxone with sulbactam, and
Initially.
initially
And later on, or you have continued on that
we have
also?
continued that. Patient showed improvement after starting him on ceftriaxone,
So it was ceftriaxone and sulbactam?
sulbactam combination.
Okay. Okay.
And the patient is now the TNO
So,
policies are
when you are actually empirically choosing an antibiotic for skull-base osteomyelitis, what is the general literature recommendation?
So
Is
the
it ceftriaxone, sulbactam?
most common organism is Pseudomonas aeruginosa. So we have to start on antibiotics that are sensitive to Pseudomonas, like third generation cephalosporins or aminoglycosides or fluoroquinolone, ciprofloxacin or carbapenems.
Yeah, immunopen that is initially is to be considered. And how long you have continued, or how long you will continue?
So we have continued the IV intravenous for 6 weeks, and then we have continued oral medications. Still now it's continuing.
Hello, beautiful presentation. So now my question is whether you prefer CT, MRI or both?
Sir, CT gives better idea of bone destruction, and MRI will give a more idea of soft tissue involvement and marrow involvement and intracranial extension. So MRI is superior to CT, but both are required together to properly understand the disease.
And there is a predisposing factor. You mentioned age, elderly aged person and diabetes.
Yes.
And there is also whether there is any immunocompromission is there or not. Immunocompromission patient, compromised patient or not, this patient?
Yes, sir, because of long-term uncontrolled diabetes, he has an immunocompromised state.
Thank you.
So nice presentation. So just 1 to 3, what are the diagnostic points to diagnose a case of skull-base osteomyelitis? Very short, 3 points.
So in science, we have a deep-seated headache, which is more at night.
Deep-seated headache or ear pain?
Ear pain or
Okay.
deep-seated headache more at night. And on
Very good.
Imaging, we have the presence of bone destruction and in soft tissue
And
enhancement.
primarily, this is absolutely you are right. That is the high degree of suspicion.
Suspicion. And uncontrolled diabetes,
Yes.
history of uncontrolled
Based
diabetes.
on that high degree of suspicion, progressively increasing deep-seated headache or ear pain more at night, and classical radiological findings. So when we are coming back to the radiological findings, why the radiological abnormality persists even after the tissue healing? Can we have any idea about this thing? Radiological abnormality persists for about 1 year, even after the tissue healing.
So the anti-inflammatory process is reduced, but the bony remodeling takes a lot of time to come back to normal.
Anything else? It is with the contrast, that is the gallium.
Gallium.
It persists for over 1 year, once it is taken up by the bone. It never diffuses so easily. For that, we have shifted to another contrast, that is?
Indium. Technetium 99.
No. Anything? It's not, I think, available here. Gadolinium, actually. Another one. Okay. Now we
Now-
can have some discussion from the audience, suggesting something.
This is a very good presentation. I think this is a very relevant case because there is no doubt that the incidence of skull-base osteomyelitis in India is gradually going up. The National AOI has taken the initiative to bring out an Indian set of guidelines which we hope to distribute at the national conference in January in Bombay. But just a few points from that, because there was a question about imaging. The essential imaging we ask for everywhere because, of course, this can present to a rural health center, it can present to a tertiary center. The essential imaging suggested is a CT scan with contrast if available, but ideally you should have a CT and an MRI. And the other types of scans, well, obviously those aren't available everywhere. If they're available and you have the expertise, then yes, you can go for a gallium scan. Or even a PET CT scan is often used. The problem with PET is a lot of these patients have uncontrolled sugar. So losing pet in that situation in FTG is not easy. And as our president said, one problem with imaging is the imaging changes persist for a long time after the actual inflammation is stopped. The clinical suggestion is we monitor both the ESR and the CRP. Even these take a long time to come back to normal. But from your initial high measurement, if they come back to within a third of normal, and the patient's clinical symptoms go away, you can assume that the active inflammation is over and you can start to take them off their antibiotics.
Now, my question is that, what is the primary source of infection? So what is your suggestion?
Sir, actually, the question you cannot ask to the speaker directly. We can discuss, and this is for the judges part is over. It is.
No, I am not asking a question. I am just giving
It
some
is also a
opinion.
judge's question. I think Dr. Dipankar Mukherjee have asked the questions.
Sir, he had a history of previous earache with left facial palsy, so I think the primary infection was from the left ear, which was there 4 months back.
So the input by Dr. Ranjan actually was very important, and so we look forward for our own association recommendations.
From
Thank you. Any more comments?
any more comments? Yes,
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 sure.
sir. Everyone can comment.
Sorry, just one comment. The main problem in these patients, if it's a lateral skull base osteomyelitis, it is easier because then most of the time you have an oral polyp, you have a granulation tissue in the ear, take a biopsy, very easy, and document, take a culture. But here the tympanic membrane was intact, mastoid, as you have seen, mastoid bone was completely normal. Only if you had to go for a transmastoid approach for obtaining a biopsy, you would have to go all the way to petrous apex. And then you land up probably with a CSF leak and blind sac closure just for a biopsy. The challenge in this central skull base osteomyelitis is that if there is nothing outside, there is no epithelial lesion, then where to take the biopsy? And this is one also additional challenge that was faced in this particular case. Because we wanted to take a nasopharyngeal biopsy because torus was bulging. But then after MRI, we saw that the whole thing is very close to the carotid in that portion. So you cannot take a blind biopsy from nasopharynx. Then we thought of doing a biopsy from here, which is also too far away. The radiologist said it's too risky and too far away. So after calculation on everything, and because clivus was the closest, because clival bone was almost destroyed. That is what the big challenge in this case, in addition to the long-term treatment and everything. Thank you.
Yeah, it is a very nice
Can
case.
I add something? Can I add something for this case, sir?
CEO, please.
The same thing that Sir said, we also need to have a proper, we face the challenge where we could not take a swab for the culture insensitivity. Because determining, in skull base osteomyelitis, these are the only two things which would determine your treatment. One is the organism, establishment of the microorganism, and the biopsies, serial biopsies whenever required. Thank you.
My question is,
No, the comments and suggestion can come as a question.
how actually the diabetic patient, it's all right, but how the infection has gone to the bone, basal bone, whatever might be. So have you got any other infection somewhere, either from the mastoid or in the ear or anything else, from which it has been sprayed to bone and osteomyelitis has occurred? What is the reason? Is it just an osteomyelitis or secondary to some infection involving
No, actually, even if it is osteomyelitis, it should have a source because the local draining areas were clinically divided with infection. So it was also a difficult thing to do a microbiological test for this. So I think now it is definitely retrospective thinking that before starting an antibiotic, a blood culture could have helped us a bit. Yeah, but that was omitted.
About skull base osteomyelitis, it involves only three bones: temporal, sphenoid, and the occipital. Temporal, sphenoid, and occipital. So sources here is probably infection from the sinuses. That is the most probable thing as we can see from this here. No other source is here, present here.
Actually, again, if I just, so the difference, the classification into lateral and central is somewhat arbitrary. We hold it to be lateral if there are obvious infective changes in the ear. If the ear looks absolutely normal, and there's no sign of inflammation in the external canal or granulation or drum, it looks absolutely normal, and on imaging, if the middle ear and external canal are normal, then by default it is described as central. But effectively, that source of infection in central can be synogenic, it can be from the teeth, it can be from the nose, it can be from anywhere, it can be hematogenous, as Professor Aichaudhry said. So we don't really know.
Now I invite our next speaker, Dr. Pragya Paromita Ghosh, to talk on piezoelectric study, role in rhinoplasty.
Very good afternoon to the respected judges, my seniors present here. I'll be presenting on the piezoelectric surgery and its role in rhinoplasty. So rhinoplasty is a surgical procedure performed to alter the shape, size, structure, or the function of the nose for aesthetic reasons, functional improvement, or both. It is one of the most commonly performed facial aesthetic surgeries that is emerging that requires precise modification of the nasal bones and cartilage. Traditional osteotomies include chisels, osteotomes, rasps, powered burrs, and with the emergence of piezoelectric surgery, it's an ultrasonic bone cutting technology that is being used for rhinoplasty. So the goals of rhinoplasty include enhancing the nasal aesthetics, achieving a facial harmony, improving the nasal function, and to restore the structural integrity of the nose. Of which, this is how a rhinoplasty should not be done. Now, the conventional osteotomies in rhinoplasty include lateral osteotomy, paramedian osteotomy, intermediate osteotomies, and transverse osteotomies with instruments used like chisels, rasps, hammers, and osteotomes. In the particular video, we can see the lateral osteotomies, paramedian osteotomies are being performed, and thereafter, the nose is being repositioned with digital manipulation. Well, now, what piezoelectric osteotomy is? Piezoelectric osteotomy utilizes ultrasonic microvibrations to cut mineralized tissues while preserving the adjacent soft tissues, which was first introduced by Versilotti in 2001. Its application in rhinoplasty has been used for dorsal preservation, precise hump reduction, intermediate, lateral, and transverse osteotomies, bone sculpting, and revision rhinoplasty. This video, we can particularly see that the piezotome is being used for reduction of the dorsal hump by rasping. Now, how does the piezoelectric surgery works? It was first discovered by Curie in 1855 that contains certain crystals which deform when electric current is applied. It produces ultrasonic vibrations in the frequency of 25 to 35 kilohertz, which are transmitted to the specialized inserts to cut the bone. The selective cutting of the hard tissue with the preservation of the soft tissue is a particular key feature that we see in case of an piezotome. The main components of the piezotome are: it consists of a piezoelectric generator, a handpiece, specialized tips and inserts for the irrigation system, through continuous cooling and saline irrigation, reduced thermal injury to the surrounding tissues, enhanced surgical visibility, precise, controlled, and bone cutting with selective action only on bone. It preserves the surrounding tissues. Now, this video, we can see this is a boiled egg over which the piezotome is being used to make controlled cuts. The surface over the egg is cut, but the underlying soft tissue is unharmed in this. This is what the piezotome does in the nasal contour also. So this was a patient, a 19-year-old male who presented to us with features of nasal obstruction, cosmetic reasons. So before any rhinoplasty, it is important to take the preoperative pictures, which includes a frontal view, a basal view, a left lateral view, and the oblique views, where we can see the facial aesthetics are altered, where there we can see a crooked nose deformity. Now, the surgical steps included dressing, draping, local infiltration with a transcolumnar incision and bilateral marginal incisions, followed by soft tissue envelope elevation, septoplasty with the reduction of the septal cartilage harvesting was done, followed by fixation of the septum to the anterior nasal spine, followed by paramedian osteotomy, lateral osteotomies, digital manipulation to correct the deviation, tip plasty, and closure. In the video, after the median osteotomy has been done, we can see that this is the paramedian osteotomy that is done. The bone piece has been separated. The similar step has been done on the opposite side, where the osteotomy piezoelectric instrument is being used to cut the bone precisely where it is required. We can see a clear field of vision with no blood dissipation, no advertent trauma to the soft tissues. After this, the digital manipulation was done and the nose was centered to the position. Post-operatively, the plaster of Paris cast was kept in situ for 10 days. Antibiotics were given for 5 days and oral steroids for 2 to 3 days. Paraffin tule nasal pack was removed the next day. The pop cast was removed after 10 days and a follow-up was done at 10 days, 1 month and 3 months. These were the post-operative snippets taken at 3 months. That includes, there is correction of the there is correction of the crooked nose deformity. The dorsum of the nose now appears central. This is the basal view. Initially, the patient had no columella and there was only lobule. Now there is a presence of a columella and the lobule that is present. Along with symmetry, the asymmetrical nostrils are now corrected to symmetrical ones. This is the lateral view. Now we can see there is a nasofrontal angle is maintained. The dorsal limb is preserved and there is a tip that was initially absent. And this is the oblique view of the patient. So, does piezoelectric surgery score over conventional rhinoplasty? The conventional rhinoplasty has a lot of pros, which includes it as being less expensive and a faster operative time. But the cons include there is a greater trauma to the mucosa, periosteum, soft tissues, increased risk of comminuted fractures, green stick fractures, there is increased risk of bleeding, lack of visibility in blind osteotomies, and the tear of the periosteum. Whereas in the piezoelectric rhinoplasty, the pros include improved visibility to improve the rhinoplasty, excellent for revision rhinoplasty and accuracy. There is decreased soft tissue edema, ecchymosis, precise controlled bone sculpting. There is highly precise bone cutting that prevents inadvertent trauma to the soft tissues around, and there is decreased bleeding. The cons include there is an expensive consumables, increased operative time, and it is not available in all the centers. So, in a study in 2024 by Garbolt et al., they concluded that piezoelectric instrumentation provides precise bone contouring and osteotomies under direct vision over 185 rhinoplasty cases. Tirelli in 2023 found that piezoelectric osteotomy resulted in less postoperative pain, edema, and ecchymosis. Scholbe et al. In 2021 found that the study said piezoelectric surgery produced more accurate osteotomies and fewer comminuted fractures compared to the conventional techniques. Giselle and Khatib in a study in 2022 compared piezosurgery, conventional osteotomies, and compared that the piezoelectric osteotomy significantly reduced postoperative edema and ecchymosis as compared to the conventional methods. So the basic take-home message is, piezoelectric device has definitely added control and precision to osteotomies, thereby providing us with a clean divisions and better vision for the work field. Hence, it can be readily said it's a surgeon's tool, but ultimately, for any surgery, the ultimate result will always depend on the surgeon's skills. So these were my references. Thank you.
Advantages of using piezotome in rhinoplasty. 1, 2, 3.
So the most important advantage here is hump reduction. That is basically when we go for a conventional osteotomy, the hump reduction cannot be done after the lateral osteotomies have been performed. So the very minute details in a nasal rhinoplasty becomes, it's not that beautifully done as we can see in the piezoelectric instruments, where hump reduction can be done even after all the osteotomies have been done. Apart from this, in case of conventional osteotomies, there is inadvertent fracture to a lot of tissues around, increased edema, increased ecchymosis. The patient's pain is increased, whereas in case of piezoelectric, all of it is reduced. There is only very precise bone cutting, very precise removal of what we want to remove.
So, precise cutting and less soft tissue injury. Anything else? Better healing.
So this use of these piezotomes are not new. They have been used for quite a long time, even in the rhinoplasty. So, but what you have described is exactly what the advantage is. You have not discussed anything about disadvantages. Anyway, what you have described is very standard textbook things that you have told. So, why you have selected this topic to present? Have you started piezotomes in rhinoplasty?
So we have had one case We had been given a demo instrument in our institute, and we did a rhinoplasty using that instrument, using a piezotome.
Okay, you have just done only one.
Yes, sir.
Okay.
But it has already been done in other centers here in Calcutta.
But previously you have been doing with the conventional technique.
Yes, sir.
Of osteotomes and and other hump reduction by what is called
RASPs.
RASPs and everything.
Yes, sir.
So what is your opinion? Were you are happy or very dissatisfied with using those conventional techniques in rhinoplasty like chisel osteotomes and RASP reduction in the humps?
So if
And
I may...
Why you are thinking that you should shift over to? Because you know what is the price of a piezotome unit?
So one piezotome unit costs approximately 7 to 8 lakhs.
7 to 8 lakhs.
And the hand pieces are approximately 25,000.
And a good RASP from a very good house is around 25,000.
25,000, yes.
So there is a vast difference in the cost. So were you really thinking of abandoning your conventional techniques to piezo?
So the thing is, with the emerging time, there is a lot of aesthetic surgeries that are being performed. And facial aesthetics is gaining a greater popularity among present times. In that case, conventional osteotomies can be done, but the precision that we obtain with a conventional osteotomy is profoundly reduced that we can obtain through a piezoelectric surgery. And it can be said it is analogous to doing surgeries with a powered instrument. Like tonsils can be done with a cold instrument also, and it can also be done with a coblation.
Right. But to really to come into a conclusion in your own hand, as you have said, ultimately the result depends on the surgeon. So you have to do minimum cases and compare it with the conventional or the piezo. So just don't say that the piezo is a magic. But this piezo really is very much necessary in ENT surgery, in some other field of ENT surgery. Can you guess? And piezotomes have been used, and it's really very, very essential and very effective.
So dacrocystorhinostomy operations or molar bone reductions in case of osteotomies.
Dacrocystorhinostomy, cutting bone sometimes is difficult, but really it's not that you need a piezo. If you don't have a piezo, you can't do it. It is actually during endoscopic mastectomies, where they are using the piezotomes, which does the bone cutting very effectively, precisely, without taking small space, without injuring your scopes. So I think it has its application in endoscopic ear surgeries, they are very good. So can I have an opinion of Dr. Raichaudhuri on this? Yeah. Sad is sad. Whenever you refer Professor Raichaudhuri, you will say sad.
I think it's about philosophy of adapting new technologies and weighing the risk versus benefit ratio. It's everything in life. Risk versus benefit ratio is all about in life. So once we have this tool, we were thinking why not try this, and then also what are the potential use of this instrument if we buy. For example, initially when we bought everyone, whoever has procured a coblation, it was tonsil and retinal. But today, with coblation, we are using regularly for pituitary, regularly for nasopharyngeal angiofibrom. So once the tool is here, if we can obtain a new tool and adapt to things, probably in my thinking that maxillectomy cuts can be done by this. Go by the literature, people have done it. So life can be made easier if we have access to newer tools, provided you are a safe surgeon. You should not, as you rightly say, you should not embark to a new technology without having, it's like calling without knowing how to do an open calling system. So I think the days are there when this will come to our basket and we'll be using this for various surgeries in the end. That's my way of thinking about the ear surgery, the mastectomy. Ear surgery, I think there are multiple things that we can use the piezotope for, which I think.
Particularly mastectomy endoscopically using a drill really is very dangerous for the scope and also the space. I think
also for making it small.
It's very great advantage of doing that.
So that's what I'm saying, that once a new tool comes, we have to try our hands and we have to audit our results and then decide whether this is a good tool or not. Literature says there is an enormous potential of this tool. This is just the beginning.
I have the one question to you. What is your opinion and your institution's opinion about the learning curve of piezoelectric?
So before learning to use the piezotome, it's very important to know how the conventional osteotomies are done. So basically first we have to begin with learning the basics of osteotomies in a conventional osteotomy. Thereafter powered instruments should come into play. So in the institute currently we have always done conventional osteotomies, and with the incoming of the instrument we have done one, and we further aim at procuring the instrument for further exploration of what more can be done. Thank you, sir.
I now invite Dr. Ankit Nashkar to speak on inverted papilloma of vocal cord, an unusual case.
Good afternoon, respected judges, teachers, and my colleague. I am Dr. Ankit Nashkar. My topic is an unusual case, inverted papilloma of vocal cord. So, inverted papilloma is commonly encountered in sinonasal tract, but it occurs in vocal cord is exceptionally rare. So, inverted papilloma of vocal cord is a rare benign epithelial neoplasm characterized by endophytic proliferation of stratified squamous epithelium into the underlying stroma. It is histologically benign, locally aggressive, and has tendency to recur. And there is risk of malignant transformation. In 1854, Ward first described macroscopic feature, utilized the term papillomatous neoplasm. Further in 1855, Bill Ruth observed the aggressive nature and he misclassified it as villous carcinoma. In late 1800, Sir Morrell Mackenzie first recognized papillomatous especially as a lesion of laryngopharyngeal system. And in 1938, Ringers coined the term inverted papilloma based on the histopathology. This slide shows that standard exophytic papilloma is growing outward, but in inverted papilloma, it is growing inward. It is an endophytic growth, and it lacks immediate malignant cellular feature, yet destroys surrounding architecture through continuous inward growth. Histopathologically, it is grossly appear gray-white and papillary surface and rubbery consistency. And it has stratified squamous epithelium. Here, stratified squamous epithelium is growing downward, but basement membrane is intact and unbreached, which is crucial for distinguishing from carcinoma. And there may be presence of intracellular bridges and coilocytosis. Now, the viral and environmental trigger are it is due to human papilloma virus, where low risk factor is HPV 6 and 11 and high risk is HPV 16 and 18. Environmental factor like chronic inflammation and cigarette smoking, occupational exposure like weeding fumes, organic solvent, and noxious agent. Here, in vocal fold, there is stratified squamous epithelium at the top. Upper layer is stratified squamous epithelium, then we have basement membrane, then lamina propria, which has superficial, immediate, intermediate lamina propria and deep lamina propria. The true vocal cord lined by non-keratinizing stratified squamous epithelium. Therefore, inverted papilloma arising on the vocal cord show endophytic proliferation of squamous epithelium. Most inverted papilloma arises from the Schneiderian mucosa, which is a specialized ciliated epithelium lining the nasal cavity and paranasal sinuses. But true vocal cord lacks Schneiderian mucosa. That's why the anatomical difference explained that inverted papilloma of vocal cord is extremely uncommon and rare. Talking about the incidence, due to its exceptional rarity, incidence is not available in our literature. Talking about the patient profile, my patient is a 58-year-old male who is a shopkeeper and having a smoking history of 20 pack a year and non-alcoholic. He presents to us with progressive hoarseness since January 2026 associated with voice fatigue and occasionally neck pain. There is sudden onset hoarseness after voice overuse and cold since January 2026, progressive worsening and voice break and vocal fatigue. which worse in the evening and having occasionally dry cough. There is no associated dysphagia or dinophagia, neck pain, hemoptysis, stridor, neck swelling, any loss of appetite, and significant weight loss. No other comorbidity is there. These negative history reduce the suspicion of advanced malignancy. The interesting part of this case is the past history. 10 years earlier, in the 2016, he underwent microlaryngeal excision of left vocal cord elsewhere. Histopathologically, at that time confirmed inverted papilloma without dysplasia or malignancy. Following surgery, he remains symptom-free for 10 years before presenting again with hoarseness. This long disease-free interval make the recurrence particularly noteworthy. Then we did fiber optic laryngoscopy. Here there is a keratotic lesion over the superior surface of the superior and medial surface of the anterior 1/3 of the left vocal cord, and there is inconsistent phonatory gap present. Bilaterally vocal cord mobility preserved, and there is a suggestive feature of laryngopharyngeal reflux disease. This is the previous fiber optic laryngoscopy image provided by the patient, which were of suboptimal quality. At that time, patient has hoarseness, and the impression was keratotic lesion involving left vocal cord. Bilateral vocal cord is congestion with preserved mobility. Histopathology on November 2016 show there is inverted papilloma. There was an inverted growth. And there is no breach of basement membrane, so there is no evidence of malignancy and no dysplasia. We did voice assessment where G3, R3, B1, A1, S3, and maximum phonation time was 9 seconds. Talking about the recurrence rate, recurrence following complete surgical excision from 14 to 35%, and most recurrence occur first 2 to 3 years after surgery. Recurrence is associated with chronic smoking, HPV infection, and incomplete excision. So long-term endoscopic surveillance is mandatory. Since recurrent keratotic lesion in smoker may harbor malignancy, histopathologically confirmation is mandatory. Based on this finding, our differential diagnosis could be from benign to malignant. It could be vocal cord keratosis, inverted papilloma, epithelial dysplasia, carcinoma in situ, and invasive squamous cell carcinoma. Management plan is microlaryngeal excision of left vocal cord mass with histopathologically examination and lifestyle modification like smoking cessation, anti-reflux measure, and long-term follow-up. Unfortunately, despite counseling, the patient was lost to follow-up, so no treatment documentation is available at our institute. Associated malignancy, inverted papilloma, primary may convert into squamous cell carcinoma, which is the most frequent presentation. If inverted papilloma is simultaneously present with squamous cell carcinoma, we call it synchronous SCC, having chance is 6.8%. If squamous cell carcinoma is developing after few years of inverted papilloma, we call it metachronous SCC, having 3.6% chances. Learning point from here is there is risk of recurrence, potential malignant transformation, and need for long-term endoscopic follow-up. Take-home message, vocal cord inverted papilloma is extremely rare entity. The exact incidence and natural history remain uncertain. Histopathological examination is mandatory. Complete excision and appropriate patient counseling are essential. Long-term surveillance with periodic endoscopy recommended because of risk of recurrence and possible malignant transformation. These are my references. Thank you.
Thank you. It is a very rare case. Also a very interesting case. So when you get such reports from your path lab that inverted papilloma, inverting papilloma in the vocal cord, so the first thing that plays in the mind is that it is so rare that it is not even found in the literature in any appreciable quantity, that whether the reporting is correct or not. So then how to confirm that it is inverting papilloma, or even with the picture that you have shown of the inverting papilloma, explaining the picture, what is your immediate thought that could it be, what is the condition where you have seen that there are retipex that has gone deep tissue without breaching the basement membrane?
It can be keratosis or
No, but the picture actually, to me at least, it has confused much more with the carcinoma in situ than with the inverting papilloma.
sir, there is no breach of basement membrane.
There is no treatment of the basement membrane. That is the histological pattern. Isn't it? Yeah, you would say that there are no malignant features in the cells. There is no metaplasia or those are suspect. Those are not present.
Sir, in that case, we will do tumor. We can check tumor marker like P53, K167. And it has not been done. Sir, actually, this patient has been treated outside 10 years earlier, so we found just that biopsy report.
And they have the same report. And the same report again here, this time.
We have not done HP yet.
Oh, you have not done the surgery?
No, patient is lost to follow up. We just.
So you are actually reporting that case, that 10 years.
That case, and it is recurrence. Yes, sir.
That is difficult to come to your conclusion, isn't it? Because the clinical picture that you have shown, the two the laryngoscopic pictures, they are similar. They look more like a keratotic pattern. Anyway, it's a very, very interesting case. If it was not lost in the follow-up, then it would have been better for us.
Exactly.
Thank you.
So it is a recurrence of inverted papilloma, not a case of inverted papilloma.
Sir, we cannot say it is an inverted papilloma recurrence or not until we are doing histopath examination again. So it may be inverted papilloma due to having recurrence chances.
2016, 10 years back. You got the HP report, previous HP report also only?
Yes, sir.
No treatment history? At that time?
At that time, we got the HP report and fibro-optic laryngoscopy report only, and he had done microlaryngeal excision of left vocal cord. Left vocal cord lesion. Then again, he present to us after 10 years, being symptom-free. In both of them, the keratosis is at the same place, anterior 1/3.
As the case is showing, the mobility, you said there is a mobile, vocal cords are mobile. You have not taken any history of the smoking or etc.
Sir, he is a chronic smoker since
Yes.
last 40 years.
That's why you are telling that it could be a keratotic mass, isn't it?
Yes.
But to me, the amount of the growth and going underneath the vocal cord and the free surface of the vocal cord, to me it will be at this moment, it will be the carcinomosity, as Dr. Mukherjee said, because probably it is not a recurrence of the inverted papilloma, rather it transforms into a malignancy to me. This is I want to mention, that's all.
So I think this patient, the treatment has not been completed yet. But because of the rarity of the condition and the suspicion that this can be either a recurrence of inverted papilloma or maybe this can be a transformation of IP into, because it is in the same location. And the histopathology slide was reviewed from the patient, and our pathologist confirmed that it is the inverted papilloma and no malignancy. So that is why, out of interest, I think it's nice to discuss that we should keep this. And one more important point, the patient was not counseled about the diagnosis. He was not aware. He just knew I had something, it was operated. I agree that always you cannot believe the patient. But ideally, if you get a diagnosis of inverted papilloma, wherever it is, you have to counsel the patient about potential malignant transformation and periodic follow-up. That is another point to be highlighted especially amongst the juniors.
Thank you, Dr. Ankit, for sharing such an interesting case. Thank you, Dr. Ankit, for sharing such an interesting case. I now call upon Dr. Anukriti to present sinonasal chondrosarcoma, a rare entity.
Good afternoon, respected teachers, judges, and colleagues. I am Dr. Anukriti and I am presenting a rare case of sinonasal chondrosarcoma. Chondrosarcomas are malignant mesenchymal cartilage forming tumor that accounts for 8% of all head and neck sarcomas and 0.1% of all head and neck malignancies. 3 to 12% of chondrosarcomas occur in head and neck region, and it arises in nasal cavity, often from nasal septum or maxillary alveolus. It frequently presents in 5th to 6th decade with higher incidence in male. So, a 56-year-old male patient presented in our OPD with complaint of bilateral nasal obstruction for a duration of 6 months and anosmia for a duration of 5 months. No history of nasal discharge, epistaxis, headache, facial pain, paresthesia over cheeks, diminished vision and fever. History of left oral fullness was there. Upon taking personal history, patient had a history of smoking for more than 20 years and had no comorbidities. No past surgical history or any known allergies was there. On clinical examination, facial symmetry is present. Nasal dorsum and bridge was normal. On anterior rhinoscopy, it revealed a fleshy mass in bilateral nasal cavity, beyond which there was no visualization of mass. On doing the probe test, mass was firm in consistency, sensitive to touch, it bled on touch, and probe could not be passed medial and lateral to the mass in left nasal cavity, while we could pass the probe in right nasal cavity. On posterior rhinoscopy, a fleshy mass peeping into the left nasal cavity could be seen. Eustachian tube openings and fossa of Rosenmuller was normal. Bilateral ear examination was within normal limits. On inspecting oral cavity, palatal mucosa was normal and no bulging over the palate was there. After thorough history taking and clinical examination, we did diagnostic nasal endoscopy, which showed mass was attached to the upper part of septum. The probe could not be passed beyond the growth as it was obliterating the entire nasal cavity. Then we proceeded for radiological investigations. So we did contrast enhanced CT nose and CT scan of nose and paranasal sinus, which showed well-defined heterogeneous mildly enhancing soft tissue density space occupying lesion in the anterior and medial wall of left maxillary sinus, obliterating the entire nasal cavity, and there was lateral displacement of medial wall of right maxillary sinus. And the anterior and posterior ethmoidal cells were involved and the opening of sphenoid sinus was involved. Then we did magnetic resonance imaging of face and paranasal sinus, which revealed large, well-defined altered signal intensity mass lesion in both sides of nasal cavity with extension and involvement in left maxillary antrum. The nasal septum we could see the nasal septum in anterior half, which was deviated to left, but could not visualize it in the posterior segment. The space occupying lesion measures 5.7 into 5 into 5.4 centimeter. No turbinates could be seen separately from the mass. Lateral bowing of medial wall of right maxillary antrum was noted. Posteriorly, it extended up to choana. Superiorly, it extended into sphenoid, opening of the sphenoid sinus and bilateral ethmoid sinus. No intraorbital or intracranial extension was there. After radiological investigation, we did DNA guided biopsy, which typically did not look like inflammatory polyp and was fleshy. So histopathology of which came out as chondrosarcoma. On histopathological examination, it showed polygonal cells dispersed singly and in sheaths on a myxoid and chondromyxoid background. Cells have abundant granulovascular cytoplasm and mildly pleomorphic vesicular nuclei with distinct nucleoli. Scattered mitosis and cartilaginous tissue bits were noted. That was suggestive of chondrosarcoma, after which we planned the patient for excision of sinonasal mass via lateral rhinotomy approach. So after a temporary tarsorrhaphy, Moore's incision was given with subciliary extension from the level of medial canthus, midway between canthus and nasal bridge in the nasomaxillary groove, curving round the left ala into the nasal cavity. Then the incision was extended 1 centimeter lateral to the lateral canthus, goes medially 3 millimeter below the lower eyelash. After that, incision is made down to the bone. Subperiosteal dissection over the anterior face of maxilla was done. Nasal flap was lifted and dissected from the nasal bone. Orbital periosteum dissected from the lamina and nasolacrimal duct was transected obliquely adjacent to the sac. Lateral nasal mass was removed. The mass was exposed and it was meticulously removed in piecemeal, as we could not remove the entire mass in toto, like in single attempt. Ethmoid and sphenoid sinus was visualized and cleared of mass, and the posterior part of the septum was eroded and mass was present in right nasal cavity, which was excised in piecemeal. Betadine soaked gauge nasal packs were given in the cavity, and the wound was closed in layers. Hemostasis was achieved and post-op period was uneventful. The sample was sent for histopathological examination, which showed a moderately cellular tumor composed of lobules and sheaths of cartilage separated by fibrous bands associated with atypical chondrocytes with many binucleate cells, and had hyperchromatic plump nuclei with prominent nucleoli. Focal stromal myxoid changes were noted. No necrosis or osteoid formation was seen. Patient was kept under regular follow-up. On post-operative 6 weeks follow-up, patient was doing well. The external surgical scar was healthy, cosmetically acceptable, with no signs of infection. A diagnostic nasal endoscopy in the post-op period revealed a healthy mucosa with no evidence of residue or crusting. This is a post-op picture of showing the maxillary sinus. Now coming on to discussion of chondrosarcoma. So chondrosarcoma can spread superiorly into skull base, inferiorly into palate, medially into orbit, and posteriorly into pterygopalatine fossa or infratemporal fossa. And the chance of recurrence is high as it is multifocal in origin. So the patient follow-up is essential. They tend to run a slow progressive course and displace local structures before invading them. And the symptoms of chondrosarcoma is dependent upon site of its involvement. There are multiple subtypes of chondrosarcoma, the conventional one being the most common, followed by mesenchymal, then the myxoid variety, then dedifferentiated type, and the last one is clear cell subtype. For a very aggressive but fortunately rare form, mesenchymal chondrosarcoma is usually seen in younger patients. It can metastasize to bone, and it involves the nasal septum and nasal cavity and sinus, and its prognosis is very poor. Nodal and distant metastases are rarely observed in chondrosarcoma of head and neck. If seen, usually it metastasizes to lungs. Now concluding my presentation, chondrosarcoma of paranasal sinus and nasal cavity is a rare tumor. Diagnosis of the tumor is made on the basis of histopathological features, and the surgical excision remains cornerstone of treatment. And the recurrent disease is more difficult to treat, so post-op follow-up is essential. Here are some of my references. Thank you.
Hello. A beautiful presentation. Can you tell something about the surveillance of these cases?
Sir, I could not.
Follow up.
Yes, sir. Patient, we did this. Patient came to us 2 months back in our OPD, and we did his OT like after a week. We did all of the investigation and we did his OT. So, patient follow-up is generally done in every week, followed by 2 weeks, and then regular follow-up is done, and diagnostic nasal endoscopy is done every 3 months to see whether there is any residue or recurrences there or not.
Whether you use any adjunct therapy?
Yes, sir. No, sir, we did not give any adjunct radiotherapy, but there are some studies which showed that radiotherapy can be given in some cases where the tumor is unresectable or it has intraorbital or intracranial extension. We can give radiotherapy in those cases in 60 to 70 grade of dose.
So your this mass was contrast enhanced?
Yes, sir.
This mass was?
Chondrosarcoma.
Contrast enhanced. Huh? So from those investigations and from literature, could you have some idea about the site of origin of the tumor?
Yes,
Whether
sir.
it is in the septum or it is in the maxillary sinus? These are the two common sites.
Yes, sir.
Huh?
Yes, sir.
For sinonasal chondrosarcoma.
Yes, sir.
Particularly in your case, from the history, from the endoscopic examination and from the radiological findings, can you guess some idea about the primary site of origin of this tumor?
Yes, sir. Since when we did the diagnostic nasal endoscopy and the probing test while examining the patient, we passed a probe and we could not pass it like on the medial wall of on the septal part. So most likely it was originating from septum and then it extended to the maxillary sinus.
So what prompted you to do a biopsy fearlessly in a contrast enhanced mass?
Sir, first we did contrast enhanced CT scan.
It was enhancing.
Yes, sir.
So how you could do a biopsy so fearlessly?
Because the patient had no history of epistaxis and it did not bled much
You
on
should
touch.
consider the other features, age of the patient, history of the patients.
Yes, sir.
These are the things.
Yeah,
Okay,
right,
thank
sir.
you.
Thank you, sir.
So just as a continuation of what Dr. Rai was discussing, your CT showed that there is a destruction of the medial wall of the left maxilla, full of the septum, but it had gone up to the lateral wall of the right maxilla.
Yes, sir.
So most
medial wall of right
probably the origin was from the medial wall of the left maxilla. And it had destroyed the septum and gone up to the right maxilla. It's not in the septum. Anyway, that's not it. The issue is that you have shown us your CT, you have shown us your MR. So after getting your CT plates and reports, why did you think that you should go for an MR?
So because MRI gives better soft tissue delineation than CT scans, and that's why, sir. And we could differentiate between whether the mass was like whether it was sinusitis, sinus collection was there, or the mass. It was a mass. That's why.
So if it was a collection, sinusitis, then what did you get in your MRI?
Sir, it would have looked slightly whitish on T2 MRI.
It would be
Yes, sir. Hyper dense. Yes, sir.
And if it is a mass?
If it is a mass, it look like, sir, it will be little darker, separating it from the sinus.
Mass, you want to confirm it is a mass, which protocol of MRI will look for? Or which sequence of MRI will look for?
Sir, T2 weighted MRI. Sir, ideally we should do both, T1 and T2.
And anything else? In that case, a DWI will give you,
Yes,
digital imaging will give you more, because if it is a solid mass, it will appear dark.
Okay.
Isn't it?
Yeah, right.
It's okay. And the second thing is, in your clinical findings that you have shown, because clinically it was almost a malignant lesion, that it was confirmed that it is clinically malignant, but you didn't mention about the status of the neck node.
Right,
that
sir.
That
Yes,
is
yes,
a bad miss. Isn't it?
Thank you, sir.
Thank you. It was a very nice presentation.
Thank you, sir.
Not a very common tumor, quite a rare tumor. And so I think this deserves good discussion from Ranjan is already raising hand, Tapun is raising hand. So please share again, Ranjan, share again. Acha, Ranjan sir.
If I say that it is rare, that means 1 in 1 lakh, 1 in 100 lakhs. Have you gone through the literature there, how much it is rare?
What is the incidence found in the literature?
Sir,
about chondrosarcoma, sinonasal chondrosarcoma?
Sir, it is 0.1% of all head and neck sarcomas.
Okay. So Ranjan?
1%?
0.1%.
0.1% of all head and neck sarcomas. The primary management of chondrosarcoma is surgical excision.
Yes.
And I think one of the possible problems you had it's very difficult. In only about 80% of cases can you get the whole thing out in a sinonasal chondrosarcoma. But I'm a bit curious as to why you decide, this should be a question, so I'll reframe it. I think perhaps in this case where you had a large midline lesion, you would have increased your chances of getting a better excision or a perhaps near total excision if you'd have done a midfacial degloving type of approach. Because the lateral rhinotomy limits you to an angled approach from the side. And this was a midline it was a bang midline lesion straight in front of you. So I think it might have been you might have got a little more leeway by doing a midfacial degloving, which allows you access from both sides of the maxillary antrum, and then you can take off as much as possible. Then there was a question of radiotherapy. I mean, traditionally, chondrosarcomas are held to be radioresistant.
Yes,
so, but the role of radiotherapy is if you've left behind a lot, or if you have disease which you've left behind because it's close to important structures, traditionally they have been irradiated. Whether that actually makes any difference in disease-free survival or not, we don't know. The new kid on the block is proton therapy. As proton therapy gives you a much more targeted dose, and you can control the dosage a lot better than conventional radiotherapy. So there is in the literature some studies on proton therapy in skull-base chondrosarcomas, which they claim gives better disease-free rates, 5-year survival rates, but there's no comparative studies, there's no randomized trials, so we don't really know. And coming back to the original paper of today, which was central skull-base osteomyelitis, one of the problems with irradiating these treatments is you may cure the malignancy, but 10 years or 12 years down the line, post-radiotherapy skull-base osteomyelitis always happens. It's a type of osteoradionecrosis, so that is another problem you face, especially if you irradiate these afterwards.
I had we have in SSKM hospital in 1998, Vikas Das. We followed up the patient still now. It is a chondrosarcoma involving the both maxillary sinus also, including septum. It was misdiagnosed as nasal polyp, and it was then operated by us. We follow the patient. Patient is still under my follow-up because he remains as in the
as the tumor has extended.
Follow-up is still very essential, and we did that. Total palatal also involved. The total palate had to be removed. Then with the dental prosthesis is still now. I have followed up. I have YouTube of this patient. Patient is very highly satisfied. So surgery. Whenever I have to do twice surgery, at least within 6 months interval, because we could not total take out some of the remnant was there. We followed up. There is nothing else, but we think it should be removed because that time radiotherapy was not given in this year, already said. So I have another patient from Bangladesh. So it is not sure yet. Though I have passed 40 years of my career in service. So it is rare and rare still. The incidence I could not also tell the whether 1 in 10,000 like that. But it should be surgery as it.
Yeah, very nice. Sir, please. As we all know, the chondrosarcoma is radio not sensitive, but it is not radio resistant, but it is not that sensitive. As the tumor has gone to the septum, medial wall of the maxillary and then the floor of the maxillary. And the approach was made is only the lateral anatomy. To me, it should be a radical surgery because surgery and the repeated surgery is the only treatment for this. So it should be Weber-Ferguson and open a bit and then remove the whole of the maxillary and then give the palatal prosthesis with the operator. So deformity won't be a great problem, but the patient morbidity and mortality will definitely be benefited.
Follow-up would have been easier, but what she mentioned, that the tumor they could not take out en masse because it broke, so you had to bring out a...
It should be a radical surgery rather than a conservation surgery.
Thank you, Dr. Anukriti. We move on to the next presentation by Dr. Roopsha Dasgupta from Nose to Cellar, Expanding Horizons for ENT Surgeons from the Perspective of a Surgeon in Training.
So, good afternoon to my respected judges and all present here. I am Dr. Roopsha Dasgupta, a DNB PGT, and today I will be presenting a case series on transsphenoidal approach to pituitary macroadenomas that have been done in our institution, and the road from nose to cellar, exploring the ever-expanding horizons of ENT surgery. So the pituitary gland is a small gland over the cellar, but it has so many functions. It secretes a number of hormones which are essential for the normal functioning of the human physiology. Pituitary tumors comes in all shapes and sizes, but not every tumor needs to be operated. The tumors, usually macroadenomas, more than 1 centimeter, which are not responding to conservative management, are the ones that we operate. So coming to the approach to the pituitary tumors, Pituitary tumors have been approached and being operated for ages now. Transcranial approach was used previously, but recently we have started doing endonasal transsphenoidal approaches. Microscopic transnasal approaches were there before, and over the recent decades, endonasal transsphenoidal approach has gained importance. So, as ENT surgeons, why do we even talk about pituitary tumors? This is because the sphenoid sinus is a gateway to the skull-base surgeries. And the road to the sphenoid sinus is the one that the ENT surgeon is very familiar with. So here, as we can see in the image, the sphenoid sinus is shown with the intersphenoid septum in between. And once the sphenoidotomy is done, we are seeing the sella, and this particular image is the one which we will be exploring in our case series. Coming to our case series, we have collected 4 cases over a short period of 3 months of my tenure. Our first case is a 67-year-old male who visited the outpatient department with diminution of vision over bilaterally, more involving the left. A clinical examination had been done, and perimetry done showed bitemporal vision loss. Appropriate workup was done, and MRI showed a pituitary macroadenoma extending into the suprasellar cistern, stretching, displacing the optic chiasma. It extended in the right to the right cavernous sinus with encasement of the right internal carotid artery, and over the left, it did not extend beyond the intercarotid line. So this patient underwent transsphenoidal approach to the pituitary macroadenoma excision. This surgery is a multidisciplinary approach where the neurosurgeon and the ENT surgeon go hand in hand. The nasal stage and the sphenoid stage is mainly where the ENT surgeon plays a role, and the sellar stage is where the neurosurgeon takes over. So coming to the nasal stage, it starts with a diagnostic nasal endoscopy. We first visualize the nasal pathway, and then we do a lateralization of the inferior turbinates to get enough space. Then a Haddad flap or the nasoseptal flap is incised with an inferior, superior, anterior incision and elevated. Here we can see the nasoseptal flap being elevated by an inferior incision. Now, coming to the next step, once the flap has been elevated and properly tucked in the nasopharynx, we move to the next step of posterior septectomy, which involves the disarticulation of the posterior part of bony septum from the rostrum of sphenoid. Once it is disarticulated, the picture we can see is that of bilateral sphenoid with the rostrum in between, a typical owl's eye appearance. Sphenoidotomy done. Sphenoidotomy is done after this, and then a planar osteotomy and shoulder osteotomy is done. Our aim is to delineate the structures and provide with this picture showing a sellar prominence with above the optic strut the planum sphenoidally, below the clivus, and laterally bounded by the parasellar internal carotid artery prominences. So once this picture has been properly delineated, we hand it over to our neurosurgery counterpart. From here on out, the sellar stage starts. The floor of the sella is drilled properly, bones elevated, as we can see here. And then a cruciate or U-shaped incision is given to approach the pituitary tumor. So here we can see in the image that the pituitary tumor has been accessed, and we use usually a two-suction approach to suck out the pituitary tumor. Once the pituitary tumor has been excised out, we can see the descent of diaphragma sella. Here we are doing a Valsalva to check for any CSF leaks. Then we move on to the next step of reconstruction. Here we can see a graft of the tension fascia lata has been placed, followed by Surgisil, and followed by repositioning of the nasoseptal flap. Once the nasoseptal flap is placed, Genfoam is placed and Merosil is inserted. So this patient underwent this transsphenoidal surgery without any intraoperative complications. Coming to the next case, our second case was that of a 53-year-old female, previously diagnosed prolactinoma case in 2022, and she underwent serial MRIs every year. In her 2026 scan, she showed an increase in the tumor by 25% despite cabergoline therapy, and therefore planned for surgery. She underwent the same surgery without any complications. Our case 3 was a 37-year-old female who came to the department with bitemporal vision loss. She underwent the surgery, and in her transsphenoidal surgery, a CSF leak was noted. This CSF leak was repaired with Surgisil tissue glue and Haddad flap. Our fourth case was that of a 37-year-old male whose MRI showed a fluid level of hemorrhagic pituitary macroadenoma. So all 4 of them went surgeries like that. 3 of our patients had presented with diminished vision and underwent the surgery. 2 of them showed crusting on follow-up in post-op 2 weeks. Post-op vision showed immediate improvement, even more so in POD1. So endoscopic approach to pituitary surgeries is indeed a great approach. It provides a panoramic multi-angle view and permits the complete excision of the tumor with a less incidence of complications and lesser post-operative morbidity. Now the road to the, from the nose to the sella is not only a road of the surgical approach to skull-based surgeries, but for a surgical trainee like me who has just begun their journey, it is indeed a road of learning, growth, and new opportunities. Thank you.
So in your case of 4 cases, how many cases had preoperative visual problem?
Sorry, sir, preoperative?
Visual problem.
Sir, 3 cases.
3 cases had preoperative visual problem.
Yes, sir.
And immediate postoperative?
Immediate postoperative, all 3 of them showed a improvement.
So you just started training yourself on face, isn't it?
Yes, sir.
So you have shown your approach to the sphenoid while doing a pituitary.
Yes, sir.
So what will be your approach to the sphenoid when you are doing a full house face or is doing it for the sinusitis?
So when we are doing a FES, then the approach to the sphenoid would be a similar one. We will be doing a diagnostic nasal endoscopy, lateralization of the turbinates. Then we will get a proper visual field. Then middle turbinate we will be medializing, and then we will be doing a middle maxillary antrostomy. And after that, anterior ethmoidectomy, posterior ethmoidectomy, then sphenoidotomy.
You shown that there is a use of medical treatment in 1 case.
Yes, sir.
Whether is use medical treatment in all the 4 cases or not?
So the other 3 cases came to us with diminished vision, and their MRI showed a significant size, and therefore we chose surgery to be the modality of treatment.
Next speaker, Dr. Industri Rang. With
So
this,
thank you.
anyone can, audience can comment of the previous presentation.
She presented brilliantly. Just comment to add some of the inputs that in the team, along with the ENT and the neurosurgeons, one endocrinologist must be included, because in most of the pituitary surgeries, in the post-operative period, the most common, I think it's around more than 60% of the patients undergo a period of transient diabetes insipidus. So, and we as a ENT surgeon are not very versed with all these issues. So, an endocrine workup and probably a neuromedicine guy should also be included in this entire team, because you know, in the present era of the medical legal issues, you must be very vigilant about regarding this team, because it's a multi-domain approach. So these are the points that I need to mention. Thank you.
Good afternoon, everyone. My topic today is navigating recurrent laryngeal nerve case-wise approach. As we all know, recurrent laryngeal nerve has two different cores on right and left side. On the right side, it loops around the right subclavian artery, and on the left side, it loops around the arch of aorta and moves upwards. Both the right and the left side lodges in the tracheoesophageal groove on the either side. Then it moves with the laryngeal branch of the inferior thyroid artery and passes deep to the inferior constrictor muscle. It enters the larynx behind the cricothyroid joint. The right recurrent laryngeal nerve has a chance of being posterior, anterior, and may pass between the terminal branches of the inferior thyroid artery. The left recurrent laryngeal nerve lies mostly posterior to the artery. In these case series, we followed the three following surgical approaches in identification of the recurrent laryngeal nerve. Lateral approach, the nerve is usually identified in the Beer's triangle in the lower lateral part of the neck. Inferior approach is followed in cases of large goiter. Superior approach, the nerve is identified at the level of the cricothyroid junction at its entry into the larynx. It is used in cases of cancer patients with extensive nodal disease, reoperative surgery, non-recurrent laryngeal nerve, and when the other approaches have failed. My aims and objectives were to evaluate the different surgical approaches and their association with reduced surgical complication, to emphasize the importance of a tailored approach to recurrent laryngeal nerve identification based on individual patient and disease characteristics. This was conducted on 36 patients who underwent hemithyroidectomy and total thyroidectomy during October 2025 and March 2026. At a ENT department at a tertiary care hospital, it was a prospective study. Inclusion criteria was all the patients between the age 18 to 68 years presented with thyroid swelling. The exclusion criteria was candidates unfit for surgery and thyroid tumors with significant retrosternal extension. 5 patients underwent completion thyroidectomy, 2 patients underwent total thyroidectomy, and 29 patients underwent hemithyroidectomy. In 20 patients with tumor size 2 to 4 cm, we went for superior approach. In 14 patients with size 4 to 6 cm, we went for lateral approach. In 2 patients with tumor size greater than 6 cm, we went for inferior approach. Following exposure of the thyroid gland, identification of the recurrent laryngeal nerve was done by the one of the following approaches in our different cases. The superior approach, after ligating the superior pole, it is easier to find the superior parathyroid gland and dissect it from the thyroid. In most cases, after superior parathyroid is dissected, we can get the nerve at the entry of the larynx at the cricothyroid junction. There is a drawback in this process that while we can damage the nerve at the entry point and result in global weakness. In lateral approach, after separating the strap muscles and identifying the superior parathyroid gland, we generally proceed to find the recurrent laryngeal nerve at the Beer's triangle. But in this particular case, we followed the Loray's triangle. The Loray's triangle is bounded by the common carotid artery, the trachea, and the lower pole of the thyroid. There is a drawback in this approach that we can damage the inferior thyroid artery. This is the Loray's triangle. This is the inferior thyroid artery that is being shown here. That is the recurrent laryngeal nerve. In inferior approach, it is done in cases of larger thyroids. In large thyroid, the anatomy is distorted and sometimes we need to cut the strap muscles. The recurrent laryngeal nerve is found in the tracheoesophageal groove near the lower part of the neck and it is traced superiorly. In these cases, due to wide exposure and excessive skeletonization, there is a chance of damage and temporary paralysis. Recurrent laryngeal nerves were identified in all the cases. In approach-wise analysis, among 20 cases in the superior approach, 4 cases required conversion to alternative approach, that is the lateral approach, so the success rate is 80%. In the lateral approach, among 14 cases, only 1 required conversion to alternate approach, that is the inferior approach, so the success rate was 93%. The complications that we faced in our series was transient vocal cord paresis in 2 cases and seroma in 1 case. In all cases, recurrent laryngeal nerve should be identified. Identification should be made in a tailor-made way, and in any difficulties, it must be converted to alternative approach. In absence of neuromonitoring, intraoperative neuromonitoring through thorough knowledge of the recurrent laryngeal nerve identification approaches is essential. In our case series, there was no statistical study done as the sample size was small. We did not include data from other centers to compare it with the other studies. Intraoperative neuromonitoring was not available at our setup. These were my references. Thank you.
So, what are the points to identify the RLN in left side? Number 1. Number 2, what do you suggest in cases of large goiter? You suggest superior approach or inferior approach, and what is the logic behind it? In cases of large goiter, which approach is?
In larger goiters, inferior approach is preferred. We can.
So inferiorly, what are the points to identify the RLN on the left side and that on the right side? What are the landmarks in inferior approach? We have some landmarks in the superior approach, that is cricothyroid joint.
Yes,
or lateral approach, that is the triangle. But what are the landmarks in inferior approach?
Inferior approach, the tracheoesophageal groove is identified and it is traced upward superiorly. From the root of the neck, it is identified.
You have shown in your picture, on the left side, it is coursing around the arch of aorta.
Yes.
So it will come vertically up. On the right side, it is arching around the subclavian.
It enters at a different degree in both the sides.
That you should mention.
Yes, on the right side, it's about 15 to 45 degree. On the left side, it's 0 to 30 degree.
Good. It is a very nice study that how to approach and when in which way, depending upon the size of your thyroid. So I just ask you a question, simple question, that despite all your efforts, you could not find the recurrent laryngeal nerve. What are the possibilities?
Yes, due to incompletion thyroidectomy due to distorted anatomy, or we cannot find.
More simple is it can be a non-recurrent laryngeal nerve.
Yes.
And secondly, in the superior approach, when you are actually identifying first the recurrent laryngeal nerve at the cricoarytenoid joint, and you see the nerve fiber, so what extra care now you should take to dissect or identify the nerve below that?
Prevent cauterization, excessive cauterization or over it.
No, actually before entering the recurrent laryngeal nerve into the larynx, it divides into 2 parts, one the adductor group and the inner. So you must be very careful that you may not be seeing the trunk of the recurrent laryngeal nerve and damage the other. And have you heard of Zucker candles node in thyroid?
Yes.
Has it any relationship with the
Yes, recurrent laryngeal nerve is deep and medial to the Zucker candle.
In which approach of your techniques? Superior, lateral or inferior?
Lateral. Superior. Yes.
You just mentioned about cauterization. I think it is diathermy.
Yes, diathermy, sir. Yes.
So whether you use monopolar or bipolar?
Neither of bipolar is preferred to.
Next speaker, and it is for the discussion time.
So once again, thank you, Industry. We got that once again. As I have mentioned earlier, that today we are fortunate enough that we have Dr. B.K. Rai Chaudhary sir, our senior most teacher or the senior most teacher of the teachers, who will present a rare case of hematemesis here after this presentation.
Nowadays, in this respect, neuromonitor is definitely essential. Neuromonitor. Without neuromonitor, the study is not.
I now invite Dr. Deepanjan Biswas to present on transcervical transparotid approach of a pre-styloid parapharyngeal tumor.
Transcervical transparotid approaches of a pre-styloid parapharyngeal tumor. Aims: to demonstrate the procedure for excision of large tumor involving deep lobe of parotid extending to the pre-styloid parapharyngeal spaces using less morbid transcervical transparotid approaches. History: a 27 years old euthyroid euglycemic normotensive patient present with the left-sided intraoral swelling for last 7 months. Insidious in onset and slow growing. Foreign body sensation only is the key sensation for throat. Clinical examination: firm, non-tender bulge over the left side of the soft palate, pushing the tonsil medially. Margin is smooth. Ultrasound guided FNAC. Features suggestive of pleomorphic salivary adenoma. Imaging: though the needed for this diagnosis, MRI is the best, but in our cases we do contrast enhanced computed tomography for face and neck. In CCT neck and face, we found that 6 into 4 centimeter heterogeneous enhancing lesions involving deep lobe of left parotid extending to the left pre-styloid parapharyngeal component. In this, that is the hyper entrance heterogeneous enhancing lesions in this slide, and the lower slide, the tumor is pushing the left carotid sheath posteromedially. Management. Though there is so many type of management for this tumor, in these cases we manage transcervical transparotid approaches pre-styloid parapharyngeal tumor. The another approach is intraorally, transmandibular, transcervical. But in these cases, we approaches transcervical transparotid pre-styloid parapharyngeal tumor. In cases, we incision is modified. Blair's incision is made in front of the ear lobule up to the ear lobule and curved to the angle of mandible and up to the upper neck creases. And after incision given, we identify the greater auricular nerve and we preserve the posterior division of greater auricular nerve, but we have to sacrifice the anterior division of greater auricular nerve. We have to identify the facial nerve by identifying the tragal cartilage and tragus point, and below and inferior 1 centimeter below and medially to the tragal point we identified the facial nerve, and this is in this arrow cranial nerve, 7 or facial nerve. And after that we identify the tumor, lower lobe, tumor of the deep lobe of parotid, and after that we identify the occipital artery. In these cases, we sacrifice posterior belly of digastric, stylohyoid, hypoglossal muscles and dissect the better exposure of this operative field. And occipital artery is ligated. After removal, after removal the dissection of the deep lobe of the parotid and delivery it out, hemostasis is achieved, drain placed, wound closed layer by layer. In these cases, we posterior belly of digastric sacrifices, posterior belly of digastric and tragal point, identifying these stylohyoid muscles also be sacrificed in these cases. Histopathology. Highly variable amount of epithelial, myoepithelial, mesenchymal component of a benign neoplasm of pleomorphic salivary adenoma in these cases. Result. Postoperative temporary paralysis in lower benches of facial nerve. After 4 months, the conservative management, this recovery, these cases. And after 1 year, there is no recurrence in these cases we found out. Conclusion. Although literature exists advocating mandibulectomy for the better exposure of large parapharyngeal tumors, the transparotid transcervical approach is a better alternative in terms of preserving vital structure with minimal postoperative morbidities in these cases. This is the reference. Thank you.
Just why it is transparotid? It is transcervical, I could understand very well, but why it is transparotid?
Parotid glands, there is two lobe, at a superficial, at a deep lobe. We approach this process. At first, we identify the facial nerve and we dissect from the superior lobe and inferior lobe, and the tumor lies the deeper lobe, and we approach between the superior lobe and deep lobe. For that, this is the transparotid approaches.
For that it is transparotid approach. It was a biopsy report was what?
By pleomorphic adenoma.
Of the parotid gland or minor salivary gland.
This case was parotid gland. Parotid. We approaches these cases in transcervical transparotid. We approaches this case, there is the two lobe, superior lobe or deep lobe. The superior, we approaches, we dissect, at first we dissect the facial nerve from the upper lobe, and we after dissecting the facial nerve, we approach to lower, deeper lobe of this parotid gland. For that, we dissect parotid lobe and for that we call this is the transparent. We identify the parotid gland tumor.
You have identified the parotid gland. You retracted it a little bit upwards.
It's a parotid gland itself. Parotid tumor, sir.
So you have removed that tumor separately from the parotid?
No, sir. Deep lobe, with deep lobe of parotid.
Oh, you have removed that deep lobe of parotid?
Sir.
No, what are the contents of the pre-styloid part component of the
deep lobe of deep lobe of parotid, fat, ascending pharyngeal vessel.
So any tumor in that region can be a salivary gland?
Oh, excessive salivary gland may be happening.
Anything else? Anything else?
Accessory salivary gland.
Where you can extend the transmastoid also.
Transmastoid. If transmastoid, the large size of tumor.
Now, just to add the input from
okay, next speaker. Just I am calling the next.
Okay. So these are the tumors actually confined to the pre-styloid compartment of the parapharyngeal space. And usually what we have been taught that these parapharyngeal tumors should be removed by cutting the mandible, by the mandibulotomy approach. What Deepanjan just missed to highlight is that these are the tumors, if by the study of the imaging, we can find that the tumor is situated deep to the parotid by doing this transparotid approach. By the question that you are asked, that why it's a transparotid? It is the transposition of the parotid gland, and through the in between the two lobes, you dissect out the tumor by enhancing your exposure by division of the digastric, number one, number two, division of the stylohyoid, and to further enhance the field, ligation of the occipital artery. So these are the additional maneuvers you need to do to widen the pre-styloid compartment actually what obviates the need of mandibulotomy. So, the soft tissue dissection in this area can obviate the need of mandibulotomy and the post-operative morbidity. This is the input that I want to mention.
Right. But Dr. Das,
yes, sir.
Transparotid and transposition of parotid are two different issues.
Two different areas.
Number one. And number two, he said that it was in the deep lobe of the parotid.
Right.
But he said it is in the pre-styloid process, not in the parotid itself.
Actually, here is also a dilemma that the tumor is actually in the parotid region. There is a barely perceptible, if you study the image of clinical image, there is a barely perceptible swelling in the tail of the parotid region. And in the FNAC from the tail of the parotid, it was found to be a pleomorphic adenoma. So it was confirmed that it was a pleomorphic adenoma arising from the parotid. Now it's arising from the deep lobe of the parotid.
Thank you, Dr. Das. Now Dr. Sheikh Jayed will present Not All Breathlessness is Psychiatric, a case of severe tracheal stenosis.
Good afternoon, respected teachers and judges and everyone present here. My name is Dr. Sheikh Jayed. Today I am going to present my case, that is Not All Breathlessness is Psychiatric, a case of severe tracheal stenosis. So my patient is a 25-year-old female resident of Survey Park, Kolkata, presented to the emergency department of our hospital on 10th June with her breathing difficulty in a collapsing state. On initial general examination, we found she was unresponsive to our commands, she was tachypnic, and she was using her accessory respiratory muscles, and she got stridor. On respiratory system examination, we found on inspection, she got suprasternal and intercostal retraction. On palpation, the trachea was centrally placed, and on percussion, the note was resonant, that is normal. On auscultation, there was reduced air entry to the lungs, and prolonged inspiratory phase and presence of inspiratory stridor was there. On arrival, the patient's oxygen saturation was 81% from the room oxygen. Her blood pressure was 90 by 50 millimeter of mercury. Random blood glucose was 200 milligram per deciliter, and body temperature was 96.3 degree Fahrenheit at that moment. The ABG analysis of that time shows a pH of 7.249 and partial pressure of carbon dioxide was 51.2 millimeter of mercury, both suggesting respiratory acidosis. Her bicarbonate level was 24.4 and lactate was 1.4. The patient initially received a steroid and bronchodilator nebulizations along with high flow oxygen therapy and steroid injections, but they did not improve her condition at that moment, and intubation was tried but failed twice. And we were referred at that time, and we performed emergency tracheostomy in the Department of Emergency, and followed by the revival and stabilization of the patient. The past history is very important in this case. The patient was a known case of psychiatric illness, and she was taking her treatment from a tertiary care hospital for the last 10 years for the depression she had. On 10th May 2026, she presented to our emergency department with respiratory difficulty due to pneumonia, which could not be managed medically there, and she was intubated at that time and put to ventilatory support for further management. And she was stabilized. After 15th May 2026, she was extubated, and she was stable for next 2 days during her stay at hospital. And then she again developed respiratory distress due to a cardiac failure she got that day. And on 17th May 2026, she got intubated, and after 6 days she was again extubated, followed by her discharge from the hospital with conservative management. After her discharge from the hospital during her stay at home, she more frequently complained of shortness of breath, which was ignored by the party, assuming it's a psychiatric complaint. But on 10th June 2026, she developed a severe respiratory distress, which was the reason she was brought to our emergency department. During her stay at our hospital, we investigated further with laryngoscopy and contrast-enhanced CT scan of the neck. And as we can see in this image, the laryngoscopy reveals there is a narrowing of the lumen of the trachea, and it's a grade 3 tracheal stenosis. The CT scan of the neck shows narrowing of the trachea at C7-T1 level, and there is a soft tissue above the tracheostomy site. So the diagnosis of this case is a post-intubation tracheal stenosis. There is uniqueness in this case that though the patient developed tracheal granulation and stenosis from her previous intubations, it was ignored as a psychiatric illness. But the patient most probably developed granulation from her first intubation on 10th May 2026, and again she develops respiratory distress due to this granulation tissue. And further, on 17th May 2026, due to this respiratory distress, she was intubated again. And this intubation second time further increased the granulation, and it progressed to tracheal stenosis. The patient was discharged, but at home she complained more frequent episodes of respiratory distress, which was ignored as a psychiatric illness. Key messages from this case we can take home are thorough investigations are needed to be done before thinking of any psychological cause, and we should look for organic causes of respiratory distress even if the patient is a psychiatric patient. And till date, a tracheostomy is a life-saving procedure where endotracheal tube, bag mask ventilation or laryngeal mask ventilation fails to secure the airway. Thank you.
So what is the, at what level was the stenosis there?
Sir, it was...
Just go to that slide.
Yes, sir.
C6,
C71 level.
C6, C7.
Yes, sir.
And what is the tracheostomy tube at what level? Level of tracheostomy tube?
Sir, T1.
T1.
Yes, sir.
What is the stenosis?
So stenosis was around C7 level. Above the tracheostomy site.
What is the cause? What is the cause actually? Very
Sir,
obvious,
due to previous intubations, there was formation of granulation.
Prolonged intubation.
Prolonged intubation and cuff pressure.
So what is the standard recommendation regarding this converting intubation into tracheostomy to prevent this type of stenosis and granulation?
Early tracheostomy should be done if there is expected prolonged ventilation is required.
Is there any institutional guideline regarding this, after 3 days or after 10 days? Or after
Sir, if it is more than 7 days, it will cause problem. In this case.
What is the permanent treatment? Tracheostomy is the temporary supportive treatment here. What is the permanent treatment here?
Sir, we can
Why you call it a tracheal stenosis? Because it is in trachea.
Yes, sir.
So tracheal stenosis has some definitive treatment. What is
yes,
that?
sir. Laryngotracheal reconstruction is one. Sir, laser resection. Yes, sir.
Yeah, what you said last, that is also another form. Tell it.
And sir, bronchoscopy, resection and anastomosis of the. Yes, sir.
Okay. Okay. Thank you.
Blood gas analysis, what was the pH value?
pH value was 7.249.
So that was alkalosis or
acidosis, sir.
But you mentioned acidosis.
Yes, sir. Acidosis, sir.
You mentioned that presentation the oxygen saturation was 80%. So then you give the bronchodilator and oxygen, I think, whether it is increased or not.
Yes, sir.
Whether the oxygen saturation increased
no,
or
sir.
not.
It did not improve her condition.
And whether you go for end-to-end anastomosis or not.
No,
permanent?
Sir. No, sir.
No.
Yeah, incidentally, this patient came to me yesterday. So this is a classical case of post-intubation tracheal stenosis. Classically, these patients come to us, symptomatically they come to us by around 6 weeks. If you take a good history, they have a history of intubation which has caused this trauma approximately around 6 weeks before presentation. This patient has typically got a grade 3 subglottal stenosis, which I have seen the CT, all the plates, which involves the first 2, 3, first, second and third rings. This patient has the tracheostomy done in the 4th ring. So we have got at least 3 rings fully stenosed, which is grade 3 plus. Considering the management, as it is a grade 3 stenosis, laser or balloon dilatation won't work. We can do a laser or a balloon dilatation, which is basically a endolaryngeal approach, only up to in grade 2 stenosis, where is only 50% of the diameter has been affected. So this is a grade 3 plus. So this patient will definitely require a resection and end-to-end anastomosis of the trachea, which is a 5.5 to 6 hours procedure. The main challenge what we are expecting from this patient when we will be doing the surgery is, after doing these surgeries, these patients have to be kept with a neck flexed position in 10 days. Now these psychiatric patients, they are a very big challenge. In the other patients, non-psychiatric patients, usually they follow what you say. But in the psychiatric patients, it's a very big challenge to titrate the dose of the psychiatric medicines and to keep them calm. 2 months back, we had a similar patient who had at least 7 to 8 antipsychotic drugs for the last 20 years. And it was a big challenge for us to manage the patient in the post-operative period rather than doing the surgery per se. So that's the challenge, and we are still not sure. We have to talk to the psychiatrist whether they can titrate the patient and keep the patient calm in the next 10 days or 2 weeks after surgery. So this patient will definitely require a resection and end-to-end anastomosis of the trachea. Thank you, sir.
Now, I request Dr. V.K.S. Rai, sir. Regarding this case, one thing I just mentioned, that, because this patient was tried for the intubation and they give the all muscle relaxant. And on that time, at least I was present, that's why the tracheostomy was done. Otherwise, the patient will go on to death because there is no way to ventilate the tube, put the tube.
So, good evening, everybody. I am grateful to the executive committee of our AOI for giving me this opportunity to talk on a case. Having hematemesis. So what is the actually importance of hematemesis with us? Patient presented with hematemesis every time comes to the surgeon, and she is having asthma, she is having epilepsy, repeated fits and all those. For that she was getting treatment. For the last about 4 or 5 months she started hematemesis. So she went, a girl of about say 21, 22 years, and she consulted the gastroenterologist, did all the investigations. There is nothing for which can give rise to this hematemesis. And she was having a consultation with pulmonologists also, who also said that there is nothing in the chest which can give rise to hematemesis or hemoptysis. So everything is excluded. Now, ultimately, she was landed to ENT surgeon. ENT surgeon, not here. She went to Bangalore, Manipal. And there she consulted a specialist. Actually, that specialist is, as we searched in Google, that he is the best ENT surgeon in Bangalore. Manipal, Bangalore. So she was treated by them in their hospital in Manipal, Bangalore. What they did everything. They did all the investigations, including CT scan of PNS and including CT scan of brain and CT scan of chest. Everything has been done. Could not find anything. But unfortunately, they have not done a nasal endoscopy. But the patient was not having any symptom of nose, except on examination we got the patient is having deviated nasal septum to the right side, and there is spur, and there is huge hypertrophy of the inferior turbinate on the other side. So with that, actually, she was not having any epistaxis. No blood is coming to the nose. That is the important thing. So how hematemesis occurs due to nasal cause? That is the thing we are to explore now. So one day, the patient was actually, in fact, the patient visited our hospital in emergency for 2-3 times, having for this emergency with hematemesis. Then one day, when I was not being able to go to attend my clinic, Boishaki was there, Dr. Boishaki Bhakat, and she was there, and when they rang me from the hospital that this patient has come and what to do, he was not coming today, so Boishaki madam is there, so shall we consult with them? Actually, in fact, before that, I saw the patient once when Boishaki was present. And we also surprised why she is having hematemesis without any nasal bleeding. Neither from anteriorly nor from the posteriorly. So nothing could be seen. Then on phone, I told her, you do one endoscopy, internal endoscopy. So she has done that. After doing endoscopy, the description that she had given to me is there is plenty of network of vessels in the lateral wall of the right nasal cavity, and those vessels are actually forming a network at the what is that called Woodruff's area. Anybody here in the junior PGTs or what is Woodruff's area? Do you know anything about that? Woodruff's area? Any juniors, not for seniors. Anybody raise your hand if you know? Woodruff's area is an area which lies in the lateral wall of the maxilla, below the middle turbinate, starting from, say, middle of the middle meatus, going up to the posterior part, posterior to the posterior end of the middle turbinate. So that area actually became suspicious. Probably she was having oozing from that area, and which was swallowed, and after that she vomited. So this type of occurrence is very repeatedly happening for last 3-4 months. So that's why actually a patient of hematemesis is so important for the ENT surgeons. So after that, what to do? She was not bleeding at that time when actually we opened the middle meatus. There was no bleeding, but occasionally she gets, and repeatedly she gets hematemesis. So we decided to explore and see thoroughly under anesthesia and do practically something on the right side, where there was a lot of network of blood vessels in the Woodruff's area, though there was no active bleeding we saw. Then under anesthesia, we started this operation did this operation in last Thursday only. Today is the second day. She has just crossed 48 hours just now. And till then, after operation, there was no hematemesis, no bleeding from nose, she is quite all right. Maybe that she is doing well. And she will be cured. That is, we hope. Now, what we have done, I request Boishaki, Dr. Boishaki Bhagat, and she was here with me. Actually, she assisted so many times in this institution, in my stapes surgery and also in cochlear implant surgery. So I requested her to come along with me for the operation on last Thursday. And I called Boishaki to come over here and to tell what operations we did and how the patient behaved during the operation. Please do come to the dais and present your case.
Good afternoon, everyone. So the procedure which was planned after looking at the CT scan, MRI, and one other investigation which sir forgot to mention was it was tracing the internal carotid artery throughout the whole body. They have traced, and there was no aneurysm also seen in the investigation. So after that, the initial planning was, of course, correction of the deviated nasal septum and removal of the spur, along with cauterization of the congested area at the end of the middle turbinate, and cauterization of the engorged blood vessels of Woodruff's plexus on the posterior end of the nasal cavity, which was more engorged on the right side than the left side, and sphenopalatine artery ligation on the right side. This was planned. So after taking up the patient under general anesthesia, after decongesting the nasal cavity, we confirmed the diagnosis of diagnostic nasal endoscopy, which was done in the outdoor procedure, as an outdoor procedure. So there was, because OPD nasal endoscopy was done at least 5 to 7 days before the taking up the patient in OT. So still at the posterior end of the middle turbinate, there was a resolving kind of hematoma which was seen. Hemosiderin deposits were seen at the posterior end of the right middle turbinate, and engorgement of the vessels were still persisting on the posterior end. So firstly, in an intention to ligate or cauterize or take control of the sphenopalatine artery, a flap was raised at the posterior end of the middle turbinate. A vertical incision was given over the lateral wall of the infundibulum, and after taking up the flap, crista ethmoidalis, which is said to be the landmark for sphenopalatine artery, was. Yeah, there was a procedure. There was a on CT scan. There was initially, when the patient had consulted in another hospital, there was opacity in the maxillary sinus on the right side. So they had done a middle meatal antrostomy on the right side. So in this procedure, we started raising flap from that end of the middle meatal antrostomy. From that, the flap was raised.
Hello. The thing is, actually, if you open the middle meatal antrostomy, you see the posterior wall of the maxillary sinus. And on that posterior wall of the maxillary sinus, you will see a raised area, bulged area, which is the actually the position of that internal maxillary artery. So after opening, so that opening of the sinus, middle meatal antrostomy, and widening the antrostomy opening, and as she did, and after lowering the medial wall of the maxillary sinus up to the almost level of inferior turbinate, then she started raising the flaps. So that is important, because after opening the antrum, you will see the bulge, and follow that while you are using or elevating the flap from the lateral wall of the sinus, starting from lower margin of the middle antrostomy opening. So that is important.
So to summarize, sir, it's the endoscopic sphenopalatine artery ligation, middle metal antrostomy,
yes.
and cauterization of the congested area, along with septoplasty and sphincterectomy.
In this regard, I want to say that for juniors, when you will do cautery or when you will do ligation of the sphenopalatine artery, or when you are to do ligation of the sphenopalatine and the ascending pharyngeal artery. Do you go for only sphenopalatine artery ligation, or you will have to go for very close to the sphenopalatine foramen, then you apply the clips. So that is important. Now when my intention is that if there is oozing, it was oozing. That's why she was not having a lot of bleeding. Occasionally she was oozing and she was swallowing the blood and she was having hematemesis. So for that reason, in that case, only ligation of the sphenopalatine artery is not enough. You will have to open up to the sphenopalatine foramen, go there, and in that foramen you see there are two arteries are coming in. One is sphenopalatine artery, the other is the ascending pharyngeal artery. So both together you will have to clamp, and what she did, she applied the clips onto the what's it called?
Sphenopalatine.
Internal maxillary artery. At the internal maxillary artery, where from the last branch is sphenopalatine artery, and below that is the ascending pharyngeal artery. So you will have to tie that if there is oozing. If there is bleeding from the sphenopalatine artery profusely, that is obvious for us. Every time we see the patient is having bleeding from anterior part also in that case. But here, as it was oozing, you will have to go for ligation. And if there is a bleeding, as you see, many cases you have seen, or we do, in bleeding from the sphenopalatine artery only, you do cautery, it is all right. It is not necessary always to tie the sphenopalatine artery. So that is my idea to say. So actually, you will have to ligate both sphenopalatine artery and the ascending pharyngeal artery. And when there is oozing, or a lot of blood vessels that you have seen in the Woodruff's area, in that case, you will have to go for ligation. Otherwise, you will have to go for just cautery.
Thank you. Thank you so much, sir, for a really an interesting case. Now it's the time to appreciate the participation of the presenters. Ushrin, please call one by one.
Dr. Debojyoti Dasgupta.
I would request our judges to please come in front of the
Dr.
stage and to hand over the
present
certificates.
the certificate to Dr. Debojyoti. Sir. Dr. B.K. Roy Chaudhary, sir, to present the certificate. Dr. Debojyoti Dasgupta. Dr. Progya Paramita Ghosh. हाँ अच्छा Dr. Progya Paramita Ghosh. Dr. Anukrit.
অজয়দা একটু পিজি ওরিয়েন্টটা বলে দাও। কই অজয়দা? দাঁড়া, এটা তোমার কাস্টমার কাজ।
So, next, in July 8th and 9th, we have the PG orientation program at the KPC Medical College. And so, also, we have we have started our 17th MediaIcon registration here, and available in the link, also available in our website for the registration. We have planned our MediaIcon 8th and 9th August in the Raniganj.
Dr. Anukriti.
And we plan to, in the registration, there is also hotel booking option, and also we have planned one bus for the go up and go through and through. Na bus free noy, kono kichu free noy, sab kichu paid. The AC Volvo bus will be available. That is, up down fare is 1,000.
Dr. Ankit Noshkar.
হ্যাঁ একদম তা নাহলে হচ্ছে ফ্রিতে কোনো কিছু রাখা উচিত নয়, তাহলে নিজের ইচ্ছা গেলাম গেলাম না যাও। So 8th and 9th July we have the PG orientation program, 2 days PG orientation program at KPC Medical College, Hall 3, Block 5, from 9 AM to 4 PM. For only for the final year PGTs.
Dr. Rupsha.
And already I hope everyone, those who are final year is not here, they have already done the registration. If anyone missed, they can do the registration.
Dr. Indushri Rang.
And this time, 17th MediaIcon at the Raniganj, we have usually we have changed our trend. We are the surgical faculty from our state usually. Recently, we have
Dr.
started
Deepanjan
this
Bishar.
time.
Dr. Sheikh Jayed.
Yeah.
I now finally call Dr. Amitabh Roy Chaudhary sir to please felicitate our judges and conclude the program.
The difficult job is done by the judge. Constantly. So thank you. With this, Thank you. Thank you. With this, we are concluding the clinical meeting today. We will meet at 8 and 9 for the PG orientation at KPC Medical College. Thank you.
Thank you, sir.